Now to Jim Ricca from MCHIP, who's going to talk to us about a study of interventions delivered around the time of birth in Mozambique.
Thanks, Jennifer. I'd just like to acknowledge the many authors who are listed here, and also thank the Mozambique Ministry of Health, the women who would participate in this study, PLOS Medicine, the PLOS for publishing this important work, and Jennifer for all of her help. And the first author listed here, Cindy Stanton, for not semi-retiring before we were finished with the study. So she actually hung on till we could finish up all the data analysis. So thanks very much to her for that as well. She can't be here today. So I just wanted to say, why did we do the study in the first place? Well, first of all, skilled birth attendance, the core indicator that's used by many for global monitoring of maternal health around the time of birth. However, this indicator really only tells you that there was a health system contact. It doesn't tell you what health services were actually delivered. And we know from various lines of evidence that quality of care really varies greatly in many contexts. And so we can't just depend on this indicator to let us know what actually is happening. Additional information really is needed for country-level planning. So the objective of the study was to test the validity of women's recall of possible new content of care indicators for interventions delivered around the time of delivery, with the intent of recommending validated indicators for the use in household surveys to help improve the specificity of information for planning and service improvements. We tried to answer two complementary questions. This methodology we used and the criteria that we were using will seem familiar, I hope, with the other things that we the other previous presentations. First, we looked at the question of individual recall, and that's how accurately women were able to recall individually what happened to them. And this depends on the sensitivity and specificity of the survey question. And we also looked at the accuracy on a population level. So at the population level, there can be canceling errors on the sensitivity and specificity, and that really depends on the level of prevalence as well that you see in the population as to whether or not those errors might potentially cancel and give you fortuitously a population estimate that's accurate. So this also, I hopefully, will look familiar. The first step on the study design was to observe labors and deliveries. 525 labors and births were observed in 46 facilities across Mozambique for a quality of care study that was being done. Then we waited 8 to 10 months, and then a different set of interviewers who didn't know what actually happened on the labor and delivery, so they were blinded to what happened, conducted household surveys, and we then compared what the results were that were obtained from the surveys with what we had actually observed earlier. I should say that it wasn't easy to locate a lot of the women afterwards. Fewer than half had cell phones, either themselves or a family member or a close friend. Many didn't have very much of an identifiable address either, so the survey team had to work very hard to find the women they did. Unfortunately, though, also we weren't able to locate as many as we hoped, but we still did locate quite a few of them. This map kind of shows, not each individual dot represents many different women, so these are not just each individual woman, but you can see across the map of Mozambique, there were women who were in this study. My one number slide here, I want to show just that, first of all, we compared the demographics for selected characteristics, age, education, and residence, among other things, of those who were in the survey with the mix. And there was a fairly close match, although women tended to be more highly educated, younger, and with urban residents than the comparable set of women from the mixed 2008 survey who had given birth in facilities. So there were 17 indicators tested for possible inclusion in national household surveys. That was from an even larger set of 34 indicators that we were trying to test, but about half we thought were candidates for inclusion on a national survey. Others we thought probably would be more likely to be included in more specialized surveys. 3 of these are already on the DHS index. Delivery location, immediate breastfeeding, I said immediate breastfeeding twice there, didn't I? And C-section rate, actually. And 14 candidates for additional indicators. So here are the results. First of all, there were 3 that met both the population criteria and the individual accuracy criterion. And that was woman delivered in a hospital versus a health center. And that's something that's a contact indicator, so we weren't as interested in that one. But that was validated on both scores. Women had a companion present during labor or delivery. There's some evidence that this decreases complication rates. So that was also validated. Newborn is placed skin to skin. That's very important for thermal care of the newborn, and that was validated on both scores. Some 4 more indicators were validated only on the population accuracy side, that meaning that there was not very accurate recall on the individual side. And I didn't explain before what cutoffs we were using for these. We tolerated a lower level of individual accuracy than was for some of the other studies that were done, about a 60% accuracy for several reasons. First, we were asking not 2 weeks or 4 weeks after the event, but we're asking 8 to 10 months after the event. So a longer period of recall. For a more complicated intervention, women aren't just going for a single illness episode, they're going to be on labor and delivery. Unfortunately, it takes, as most people in this room will know, but I haven't personally experienced, it takes a while to have a baby. So someone is there for an extended period of time. Many things are happening at one time or over an extended period of time by multiple providers a lot of times. So it's not quite as easy to know what's going on or to recall it either. And unfortunately, most women that we were interviewing don't really have probably a very clear idea of the sort of things that should happen to them on labor and delivery. So there's not sort of a framework that they can put this in to be the way there might be if they're going for malaria, where they are thinking that they're probably seeking a medication and they're able to say, I got it or I didn't get it. In this case, they're getting injections, maybe they're getting an episiotomy, they're allowed to or not allowed to have a companion, et cetera, et cetera. There are many things going on. So in any case, to get back to this, 4 of these indicators did not have very accurate recall. It didn't even make the 60% threshold for accuracy, but at the level of population prevalence that we had, those errors canceled, and we came within 25% of the true population coverage. And that was, women had her blood pressure taken. People will recognize this as something important for screening for preeclampsia. Women received fundal massage after delivery of a placenta. That's a component of active management of the 3rd stage of labor to prevent postpartum hemorrhage. Newborn dried and wrapped, newborn immediately dried, different indicators that we were testing for thermal care of the newborn. I'm going to get into some indicators that we would not recommend for household surveys. They met neither criterion. That is, first of all, women was asked about her HIV status. This was a surprise to us that that was not accurately recalled. And different ways of asking about active management of 3rd stage of labor, either the full-on 3 components of active management of 3rd stage of labor, or just asking, did she receive an injection within a few minutes after the birth, or was there controlled cord traction that was placed on the umbilical cord? Some newborn indicators also that did not meet the threshold. Breastfeeding of the newborn initiated within 1 hour birth, and I have something to say about that later, but really the idea of 1 hour of birth I think was difficult to actually place correctly. I think Stan Yoder, who was involved with the Saving Newborn Lives study, looking at this indicator as well, will probably be smiling as he sees that. And newborn thermal care indicators, again, we asked again about several different ways to conceive this indicator, but none of these pass muster either. Unfortunately, because we had as difficult time tracking down as many women as we wanted, afterwards, the sample size was a bit smaller than we were originally hoping, and several of these other indicators were not able to be checked. Women delivered by C-section, and women asked for a urine sample, again for screening for preeclampsia. Those we did not have sufficient numbers to be able to check. So, what do we feel like were the study strengths here? First, we had close to a nationally representative sample. Not exactly, but it was not done in a single area. And also this is done in a country that is a priority high mortality country. The reference standard that we used was direct observation rather than chart review. This is in a place where you would have difficulties on both sides, people charting things that didn't really happen or not charting things they really did do, so we didn't really feel like that was a fair reference standard. The follow-up period was not as long as DHS, but fairly comparable to MCHIP being 0 to 24 months after delivery, so the average would be 12 months. This study had a 9-month average follow-up time. And 11 of the 12 interviewers were recent DHS interviewers. We were able to go back and grab these guys and get them to do this study, so fairly comparable data collection with people who are used to this kind of thing. So limitations, though, on the other hand, we were not able to locate 1/3 of the women in the sample. We had no real ability to come up with a very accurate, as it turned out, or realistic. So we had a sample size calculation, but we were hoping to get 80% follow-up, and Harry was saying you can't really do a study without doing a sample size calculation. We certainly did that, but we were probably a little too ambitious in our ability to follow people up. It turned out to be quite difficult. There was some bias in the sample toward more educated urban and younger women, but relatively close, I think, to what was nationally representative. We couldn't validate a couple of indicators that we cared a lot about because of the smaller sample size. So the indicators that were validated for household surveys, contact indicator is already on the DHS and MCHIP, that's hospital versus health center in terms of location of delivery, and 2 new content of care indicators, and that would be presence of a support person during labor delivery and also placement of the newborn skin to skin. So as far as we know, this is the first published validation study of maternal recall of routine care provided around the time of birth in a low resource setting. Clearly, further studies are needed. Population Council plans on doing another study beginning soon, or maybe it already has begun, in Africa and Latin America. We'll be very interested to see what those results are in a different setting. We also hypothesize that if women are more informed about different aspects of labor, not just kind of generally well-educated, but specifically know what to expect from labor and delivery, that they're probably more likely to be able to accurately recall what happened. And clearly, further qualitative research is needed to be able to formulate the questions well in a way that is more likely to get accurate recall. So I just wanted to close with a couple of thoughts. First, we feel that clearly household surveys could immediately be improved by adding some new indicators. That list is not as long as we would have liked for new indicators that could be added, but maybe Fred Arnold and Attila are breathing a sigh of relief that the list is quite short. And with further study, we feel that some other indicators might also be improved. But we feel also that there is definitely in this particular realm of interventions delivered around the time of delivery still a role, and probably always will be a role, for some sort of facility survey to link to those population surveys, because some things it's just more appropriate to get that information from facilities. So thank you very much for your attention.